computer. Awesome. Okay. Sometimes technology is not your friend. Okay, so first of all, thank you for joining us. And I want to thank Emily for taking the time out of your Saturday morning to come on and chat with us about pelvic floor health and stuff. And so if you have questions, put them in the chat so that I can see them, and I'll reference that as we kind of work through everything. And then I kind of want us to go in the direction of just kind of give an overview of like what we're going to cover. I like to kind of preface things. So we'll talk about understanding your pelvic floor first, like what it is, the muscles of it, how it works, some common problems, special circumstances, feeling your pelvic floor. So I think it's really important to learn how to feel what's going on. Emily, you probably do too. And so we'll talk about that a little bit, and then activating your diaphragm, which is something that I do with all of my people that come that have issues. And then a little bit about breathing mechanics, and then some exercises to do at home, and then a little bit of Q&A. And so anything that we're not covering that you have questions on, just post it in the chat, and we'll just address that as we kind of work through things. So Emily, let's start off with what is the pelvic floor, and I'm going to let you just kind of get us going and talk about that a little bit.
All right, so I brought my handy dandy pelvis today. Can't go anywhere without it. I had to like turn around yesterday because I was like, I can't forget my pelvis. So essentially, this is our pelvis, just to give you a little bit of context. These are our kind of last two vertebrae in our back. This is our sacrum. Here's our tailbone. These are kind of our side waist hip bones, and this is where your kind of ball and socket hip would be. Here's your pubis, that bone in the very front, and then on the inside of that is our pelvic floor. So pelvic floor kind of sweeps from pubis to our sit bones under here, all the way to our coccyx, and all of them attached kind of in the inside bottom of the bowl. So essentially, we kind of call this the floor of the core. Obviously, here's where rectum would be in females and males. Everybody has rectum. Vagina for females. Obviously, males don't have that. And then there's the urethra. So actually, males and females have the same muscles. Females have about 1 to 2 extras, but otherwise they're the same, just kind of redistributed differently. So pelvic health is just as important in males as it is in females. And we'll kind of talk about some benefits for males as well. But basically, all these muscles kind of attach to the inside of the bowl and kind of sit on the bottom. So they're responsible for supporting all of our organs, urinary control, bowel control, being able to kind of open to release urine, release your bowels as you need to. They're really big components as far as continence, not leaking, with laughing, jumping, sneezing, being able to hold things when you feel the urge to go, and then on the other side of that, being able to let go when it's time. So when it's actually time to release your bowels, that you can relax the pelvic floor and let it go. And if you can't, sometimes that kind of can be a big contributor to constipation for some people. Obviously, because it sits in the entire bottom of the pelvis, right? So we would have kind of psoas and all those guys coursing across the front. We'd have all of our glutes sitting back here and all of our low back muscles coming all the way down and attaching to the tailbone. So the pelvic floor plays a huge component in core stability. It's really the floor of the core. So in my opinion, we can't talk about core stability without addressing the pelvic floor in relation to hip, in relation to back, and abs and diaphragm. They kind of all make this nice core cylinder. So if anybody's kind of dysfunctional, so if you have a hip problem, a lot of times the pelvic floor will kind of jump in to try to make up for that. If you have a pelvic floor problem, sometimes your hip muscles will kind of overcompensate for that. So anywhere in the system that can have a problem, you can have one area kind of compensating for the other. So
awesome.
I always tell my patients kind of the most important thing with these muscles is the ability to move through a full range, right? So if we think about like an elevator going from floor 0 to 10, we should be able to relax all the way to floor 0, take it all the way up to floor 10, and then be able to come all the way back down to floor 0. So the problem with people that are too tight, they take it up to floor 10, only come down to about 7, and then their muscles are tight and weak. The problems with kind of prolapse is they can't get it up to floor 10. They may be stuck, they maybe can only get to floor 1, floor 2, and may not be able to kind of get it back down. So having full excursion where we can draw it all the way up and in, relax it all the way down is crucial to its function.
Okay. Talk a little bit more about prolapse. Some people may not understand what that is. And so just explain that a little bit for us.
Yeah. So because of where the pelvic floor sits, all of our organs would kind of sit right inside of this bowl, right? So our rectum would sit right here, the uterus would sit right on top, and then we have the bladder a little bit closer to the pubis. And so with prolapse, essentially those organs are kind of sinking into the vaginal canal, or they can even kind of come out of the rectum. They can actually kind of exit the body, which that's in the case of a more severe prolapse. So that means your muscles aren't doing any kind of work as far as supporting your organ, and they are kind of actually dipping into the vaginal wall, which these people, if it's the rectum, constipation will be an issue, or sometimes fecal incontinence, so unable to kind of hold number 2. If it's more of a bladder prolapse, then stress incontinence is going to be the main thing, along with kind of feeling like heavy, dull pressure. And sometimes if you look down there, here, you may see something that kind of looks like a piece of bubble gum, and that is actually kind of one of those organs sinking down into the hole and not being supported where they need to be.
Wow.
So
that's pretty serious.
Yeah. And I mean, sometimes those issues, it's more typical for them to occur after a more traumatic delivery. So if you had a grade 3, grade 4 perineal tear, with a vaginal delivery, those are more common. If it was a forcep or vacuum assisted delivery, you'll see more of those. Or if you have kind of a systemic hypermobility, like an Ehlers-Danlos kind of situation, then those issues can occur there as well.
So they're more likely to occur with women who've been through the childbirthing process. Not like, do you see them in women who haven't given birth to children, or in men?
Occasionally you can see those issues in men, but usually not. Men with pelvic floor issues tend to swing to the other end of the spectrum and have more pelvic pain, tight pelvic floors, as opposed to organs not being supported and kind of falling out.
Okay.
So those issues are absolutely more typical in women who have had vaginal births, and also menopausal women. So sometimes even if you haven't had a child, but then all the hormone changes kind of occur with menopause, once we lose estrogen down there, it's a little bit harder for our tissues to function.
Okay. Hormones affect everything, I swear.
Yeah.
Okay, awesome. So let's talk a little bit about just some general common problems that people see, like the incontinence. Maybe expand on that a little bit. Tightness and weakness and coordination issues that may happen.
Sure. So there's kind of different types of incontinence. Incontinence is kind of leaking urine or feces. So stress incontinence is the kind that happens with coughing, laughing, jumping, sneezing, running, jumping activities, anything that would cause a kind of stress up above. And essentially, like, your pelvic floor can't maintain that tension and we leak. So a good Kegel contraction is a kind of lift of this back wall and a squeezing of these superficial muscles. So I call these superficial muscles like the clampers, right? So they kind of clamp it all off. And so with stress incontinence, either we aren't getting the lift, or we aren't getting squeeze, or we aren't getting either. And so we jump, we sneeze, we cough, we have some kind of pressure from up above, and our pelvic floor can't combat that, and we leak. So sometimes that's because of a prolapse issue. Say the bladder's kind of peeking down over that pubis every time they cough or laugh or whatever. Sometimes it's that they're too tight, and so it's weak. So that would be like if you had your bicep at full range, at a full curl, then you had a dumbbell, and you can't be strong at the end range. So it's the same thing with the pelvic floor. If it's hanging out at floor 7, 8, and then you ask it to contract, it doesn't have a lot of room to go, so it can't be strong, right? And so those people, like, Kegels are not the answer, because they're already way too tight. And so if they're just Kegeling away because they think that's going to help them stop leaking, then that's just going to make them tighter, and their issue's not going to go away. Okay. And then the other issue is, and this is not exclusive to women after birth, but this is very typical of people that have incontinence. So our normal reflexive strategy is, before we cough or sneeze, we kind of draw up, and then we cough, sneeze, whatever, and that keeps us from leaking. But a lot of people that have incontinence, when they go to cough or sneeze, their pelvic floor actually kind of opens. They're kind of, and so then everything leaks out. And that's strictly a coordination issue because they should be drawing up before they cough instead of bulging out. And so like some cueing with that makes all the difference in the world really quickly. The people that are tight and weak are really easy to treat. And the people that just have poor coordination, you can fix those folks quick. Because that's just like, let's just get these people to contract at the right time when they're doing certain activities. So prolapse can be a little trickier.
Yeah. I really actually had to work on the coordination thing after I had my daughter because I had issues like when I would sneeze and it would almost feel like the bottom was going to fall out, so to speak.
Right. Yeah.
And so I really had to intentionally kind of like contract myself before I would sneeze because outside of like any issues that are going on, it's actually uncomfortable when that happens, you know?
Yeah, because essentially when that happens, it's like, and everything's just like falling into the vaginal canal, and you're like, oh my gosh, my bottoms are about to fall out. I tell my patients, I'm like, you got to squeeze before you sneeze. You know?
That's a good way to put it.
Yeah, and the easiest way to practice that is with coughing, because we don't know when we're going to sneeze, but you can start with like baby cough. So I'll have, you know, after we make sure that they're not too tight, right? And I know that their pelvic floor is moving through the full range. And I have them come all the way down, come all the way up, hold, cough. Come all the way down, come all the way up, hold, cough. And then they can start to practice that coordination.
Well, yeah, and they can do that at any point. They don't just necessarily have to do that with you.
Yeah. So that's like a really easy homework item for them. And then when they sneeze, I also have to tell them, you know, the real common pattern is just like cross your legs and hope for the best.
Yeah.
You know? But that's not utilizing pelvic floor. That's utilizing adductors, which are the ones that kind of move our hip in and they attach right here. We'll get some overflow of those to the pelvic floor. But that's a really common compensatory strategy that people use. It's just like crossing the legs and trying to get adductors, but that really doesn't help facilitate your pelvic floor if we're actually trying to get it stronger. So I'm like, no crossing your legs. You practice at home.
Good. Awesome. Okay. So then speaking of Kegels, because you've been talking about like contracting and relaxing and how far the elevator and stuff goes up. So how about like Kegels for men? Do they work for men?
Yes, and it's actually very important for men to do Kegels. There's tons of benefits for men strengthening their pelvic floor, especially heavy lifters. Those are the ones that can kind of end up with some of those prolapse issues if they don't have a pelvic floor because they don't have a good pelvic floor support because they're kind of loading everything from the top and then getting a really heavy push from the bottom. And depending on like your lifting technique, some power lifters, you know, kind of brace with an inhale kind of at the bottom and as they kind of push up, and that just creates tons of intra-abdominal pressure. And for men, like there's only one place for it to prolapse, and it's the rectum. So like you definitely don't want your organs falling out of your rectum. And so like if you're a power lifter, it's essential for men to kind of do some pelvic floor work, the appropriate stretching and then contracting. So men, the best cue for them is to kind of watch themselves in the mirror naked. And when they try to do a contraction, you should see testicles elevate without anything else moving. And so if they're sitting there watching and you can see testicles elevating, then they're getting that good lift from the pelvic floor. There's also tons of stuff kind of coming out about how pelvic floor strengthening can assist with erectile dysfunction. There's several muscles that kind of sit right at the base of the shaft that if you can get those stronger, they can kind of clamp it closed and it can improve with erection. So tons of benefits for them.
That's awesome. Men would love to know that.
Yeah. So, and it's the same thing. It's like we're getting a nice lift on the back end and then a squeeze. So it's a lift and a squeeze. So if they're watching, it's just like they should just see testicles lift just a little bit. Right. And it's, do what? No, go ahead.
I was going to say, I feel like that's a good marker and cue for men because I have a hard time a lot of times communicating for a male how to like draw himself up. But for women, we just kind of know, especially if we've been through the birthing process.
Right.
And so for men, it's really difficult for me to communicate like just pull your bottom up, and like they're like, well, I don't know what that means.
Yeah, I mean the best cues, because like with women, I can be like, okay, because you try a million different cues to kind of get what kind of strikes is like, oh yeah, I can connect with that cue, right? But with women, I can be like, try to pretend like you're sucking a smoothie up through a straw, and or like you're sucking something up there. But with men, that just like doesn't compute. But when I'm like, try to elevate your testicles, they're like, ding, got that. So,
that's awesome.
And most people, if I say, try to contract like you're not gonna pass gas in an elevator, like most people are like, oh, I can do that. Like that you're really trying not to pass gas, because essentially that's like a nice good contraction. But then we should feel it, be able to relax all the way down. And if not, it might be kind of hanging out in the tight category. And so like a lot of people that are really tight, right? So kind of switching. Sorry, is that Wave Runner too loud? Can you hear that?
No, well, a little bit, but it's fine.
Okay. So a lot of people that are too tight, when I look at them, it all looks kind of sucked up in there. But just as for them feeling it, a lot of times they usually present to therapy with complaints of kind of this deep hip pain. So they'll be like, my butt aches. They have sit bone pain kind of right here, kind of pain with sitting. It feels like it's like you shot an arrow kind of right through here, like right through my butt in the front of the hip. Something in there hurts and I can't touch it. And that's usually pelvic floor.
Okay.
So this guy, so this is kind of a bottom up view. This is inside of the sit bone here. There's a muscle here called the obturator internus, which is actually a hip muscle, but has a lot of pelvic floor components. So it's inside of the sit bone, but main muscle belly kind of in here. This is a giant contributor to the sit bone pain. So a lot of people may think, oh, I just have like a hamstring tendonitis or something like that because they attach there too. But a lot of times it's that guy that's the biggest contributor to that. And it can be a huge kind of pelvic floor pain driver as well. And so with those people that are kind of too tight, and again, they kind of present in that deep, achy, they have really poor excursion. So they feel like when they do a Kegel, it doesn't go far. So they feel weak, but it's actually because it's already at the end range. So a lot of times if you can loosen it up, then then they can start to contract for a lot better. So those people, like, I don't start any kind of Kegel work with them until they have a lot better excursion. So
do you is getting a tight pelvic floor to relax, is that something that you have to do like manual therapy with to get that to do, or are there exercises that you could do on your own to
there are some certain stretches that you can do that I put on that PDF that I sent you, like happy baby, some deep squatting, some good kind of child's pose with the tailbone up are all good pelvic floor stretches. You can also kind of get in there on the inside of the sit bone with a lacrosse ball, and you can start to kind of work some of those out. And then there are different wands and things that you could buy to help you kind of get some manual release on the inside, like as far as like have you ever seen a Theracane for the shoulder?
Yes.
You ever seen those? They have those, but like for the pelvic floor.
Oh wow, that's awesome.
So like if there was a trigger point in there, so if, we identified that your obturator internus was a really big problem, you can try to release it manually inside with your hand, or they have certain wands and stuff that you can use. So usually if it's like a problem in the kind of deep aspect of the pelvic floor, the obturator, I usually recommend a wand because that just gives people a little more leverage, and then they can kind of manually work on it themselves.
Okay. So. And speaking of the PDF that she mentioned, she sent over, it's just several stretches that you could do to help with pelvic floor issues. And I'll send that out to everyone tomorrow when I send out the replay link. I'll include that attachment for you from Emily. And so it's really nice of you to send that over. I appreciate that for everyone.
And the other thing kind of about those kind of tight pelvic floors, just, oh no, where'd this go? Sorry.
Yeah, you're okay. Got you.
It's also not unusual to see those kind of tight pelvic floor issues with hip labral pathology. So if they have a labral tear of their hip, or they have hip impingement, a lot of times the pelvic floor is involved there. Or if they have diastasis recti, then a lot of times if the abdominal wall is not functioning well, then the pelvic floor, if it's, you know, intact and functioning well, it will a lot of times swing to the other side of the spectrum and be really tight trying to make up for that. I also see that a lot in people that, you know, were induced and they went through labor and then, you know, labor was unsuccessful and they ended up having a cesarean birth.
Yeah.
So their contractions, you know, were all like you would have during normal birth, and their pelvic floor tightened up during all those contractions, but they never got the stretch of birth. And so sometimes after a cesarean birth, their pelvic floor is tighter than it was before. So, but not in a good way, in like a dysfunctional way that hurts. And obviously, pain with sex is a big limitation, right? And so if your pelvic floor is healthy and has full excursion, you should be able to do whatever you want in any position and it shouldn't be painful. So if you're like, but I can do this, but I feel pressure in my butt or I feel pressure in my back, then that's usually a problem in the deep layer. So every position, whatever way you want should be fine. And if it's not, there's usually a trigger point or something in there. That's usually kind of a more of a tight in a certain area kind of problem.
So pain during intercourse is really a sign or symptom of something deeper going on.
Yeah, I mean, that should never be painful. And I mean, if we're going to get into the weeds here, there's two, you know, we're already here, right? But I mean, there's two, because we have our superficial muscles here, you know, our clampers, our superficial muscles. So occasionally after birth, if somebody's having an episiotomy here, if that scar is limited, you know, you can have pain with intercourse. But essentially, if this first layer is the problem, it's more insertional pain, or if the scar is really limited, it's more pain with insertion. It's more of a problem back here, or these are more of the issue. It's more pain with deep penetration. So,
okay.
Yes, but that should never be painful.
Yes, I agree. Okay, so I want to backtrack just a little bit because you mentioned diastasis. And I know that like women get that, especially after going through the birthing process and having a baby, but men also get it a lot of times if they're heavy lifters, and so they get that diastasis. So can you explain a little bit just what that is? Because some people may not fully understand that. And then how do you help that?
Yeah, so let me get a little.
Let me pull up an image.
Yeah.
Do you want it to be just of the muscles, or do you want it to be of, and I may
yes.
Dark.
Get,
do you want it to actually be the diastasis?
I'm gonna move this side. Like everybody's on there. Trying to explain. Hold on 1 second. Let me get an image of that.
What I can do, Emily, is I can share screen.
Perfect.
And okay, I'm just gonna show one of kind of before and after of what it looks like. So let me share screen. Okay.
And this is a topic that
can you see that?
I think, yeah, this is a topic that we could spend like a whole nother one of these on, right?
Oh, good.
Because this is like a big issue that lots of people have, both men and women. And essentially that tissue in the middle is called the linea alba, which connects kind of both sides of our rectus abdominis with the six-pack muscle. And so that can be stretched either above the belly button, at the belly button, or below. And when that happens, so that can be pregnancy induced, that can be, sometimes we'll see this after people, you know, have had a little bit more intra-abdominal adipose tissue, a little more intra-abdominal fat, and then they lose a lot of weight. Sometimes these are kind of underneath. It's not unusual for these to be accompanied with a hernia. And to me, both of these are pressure problems. So when you have that diastasis and that gap between that muscle, it cannot generate tension. And so like people will be like, my core is really weak. I feel like I can't get up off my back. I get up, I have this really large dome or this coning. Is what you'll see when they try to get up. And so you kind of measure those with finger widths. And so how wide is it, how deep it is. And so the wider and deeper, the worse it is as well. And so the key to that, talking about that kind of cylinder of the core. So when that's not functioning well, we cannot manage our pressure there, then you'll start to see people cone and dome. So they'll get up and they'll have this kind of mound cone in the middle. So they'll get up and this whole kind of area in the middle will be kind of poking up. Go down a little bit. Let's
This is a good example where you can see it, because so people that are really lean and sometimes like competitors, you can actually physically see the separation, and so you can actually see like this is her rectus right here and right here. So, okay, which one do you want?
And that like that on the bottom left where it looks kind of creasy and it kind of dives in a lot is a lot what they look like, or people will tell me like my belly looks pudgy or whatever, and a lot of times it's that they have a little space there and they can't generate tension. So if we can't generate good tension and pressure and manage our pressure at in our abdominal wall, then a lot of that gets shoved down. So then if your pelvic floor isn't having any issues, it'll try to lift up extra to help recruit for that core stability, because we have the kind of front part of that cylinder that's not managing pressure well.
This is a...
Hold on one second. I got to grab my computer.
Yeah, no, that's fun. To me, this is a good example of what coning looks like. It's kind of, really, it's just kind of like a bubble that happens. And so you can actually see that she looks like she's going to be pretty soon post birth.
Yeah, that's a nice example of a good cone, right? So you'll see that when people try to get up from a laying flat position or they try to do a crunch, they get this nice cone there, and that means that they're not kind of generating any good tension around their abdominal wall. And so then a lot of that pressure just gets shunted down. So if they were already kind of a little more inclined to a prolapse, they can't manage their pressure in their abdominal wall, then some of that gets shunted down and can make some prolapse symptoms worse. So the deep part of the abs, the transverse abdominis, actually closes the floor of the linea alba. So people can get really fixated on the gap, like, how big is my gap? Measure it today. Well, my gap is getting so big. And I'm like, it's the floor. Like, we got to close the floor of the gap and get that transverse abdominis working so that you can maintain tension across your abdominal wall. But like I said, this diastasis is like, whoo, man, you can get like real in the weeds with that.
Yes.
But it absolutely contributes to these issues.
Yes.
And it's not unusual for me to see somebody with stress incontinence that has one of those. Because they can't maintain tension and pressure well in their abdomen, and all that just gets shunted down in their pelvic floor, can't manage it, and then they leak.
Okay.
So,
and so I'm going to come back to the pressure system, but I just want to touch on people with chronic low back pain. Is that something that you would look at pelvic floor for in men and women?
Yes. So a lot of times, the low back with chronic low back pain, it's a symptom of issues that are happening other places. So a lot of people that have that kind of real arch lordotic back, they oftentimes have really, really, really tight hips, right? So they don't get any mobility or hip extension through their hip when they're walking, when they're running, when they're squatting. They don't utilize glutes at all. And so all that load gets shunted to the back. Pelvic floor kind of goes right along with that. But I tend to kind of work on hip mobility and stuff first, and thoracic mobility for them first. But it's not unusual to see pelvic floor dysfunction with people with chronic low back pain. But it tends to be more issues with constipation and things like that as well. And again, like, it's somebody that may have that kind of real arched back and maybe a bigger abdominal cavity. A lot of times, like, if they can't get good use of those abs because their abdominal cavity is a little bit bigger, and all that pressure just gets shunted down, and then we can have some of those stress incontinence issues. So.
Okay. And I do the same when people come in and they have chronic low back, is I go to hip mobility and thoracic spine first. And also, what was I going to say? I totally lost my thought. Glutes. Glutes are your butt muscles, for those of you that don't know, and they're super, super, super important for your body being able to move around properly. And I would say that probably 95 to 99% of the people that I work with, their glutes are just completely shut off and they don't work at all. So that's like a major
I
thing.
agree. Yeah.
It's a super high percentage. And even people who are like extreme athletes, like CrossFitters, like it's even that high of a percentage of the CrossFit athletes that their glutes just don't work. And they have nicely developed glute musculature. I mean, it looks great, but it doesn't function properly. They're just shut off, and either their hamstrings are taken over or their low back takes that load. And so really internally, in talking about their internal pressure system, who knows what's really going on in there.
Right. And a lot of those people, they kind of, if glutes sit back here and it's right here. They're quad dominant. They use hip flexors and low back, and they drive from their quads, hip flexors, and low backs, and they just completely skip these.
Yes.
And I'm like, and then they always complain of like this QL tightness that just will not go away. And it's because they completely skip their glutes and they don't have that good hip mobility, and they just skip it. And they're just all quads, all hip flexors, all back extensors.
Yeah. And I'm like, I look at them and I'm like, how are you functioning?
Right.
I know it's through compensation, but still I'm like, doesn't your body hurt? Like when I watch people move, sometimes I just internally, I'm like, your body hurts. You just don't know it.
Right.
So, okay, well, let's talk about the pressure system a little bit and get into like breathing and breathing mechanics. And I do a lot of activation, diaphragm activation. And so when we're talking about the pressure system, it's actually like 4 parts. So it's your diaphragm, your pelvic floor, some of your inner spinal muscles, and then some of your deep core muscles in front. So it's actually almost like a box, kind of. It's the top and bottom and back. Yeah, cylinder. And so it's this piston-like system that when you breathe in, it should move this way. And what I find is that people breathe in their like neck breathers or chest breather, high chest breathers, neck breathers, and they don't breathe into the lower part. Or when I try to get them to sync it up, it's like the rest of their body moves, but the pelvic floor is always the last piece of the puzzle, and it's the most challenging for them to get to sync up. So let me hear your breathing stuff, and then I want to show people how I activate their diaphragm, because I kind of work it from an opposite sort. I do a lot of work in opposites, and so I don't fully know this to be true, but I think of it like the diaphragm is opposite of the pelvic floor. And a lot of times people's diaphragms will just shut off, which shuts down a lot of things in their body because breathing is so important. And so let's talk about breathing mechanics and the exercises that you do, because I want people to be able to walk away with some things that they can do at home and they can work on them. And it's going to give them some improvement, even if it's just to feel better and to reduce their pain a little bit.
Yeah, I agree with you. I mean, diaphragmatic breathing is like one of the most foundational pieces, because before I even start working, because I like to cue pelvic floor contractions with an exhale with transverse abdominis, so I can get like the whole system working together. So if they can't exhale or inhale for that matter, because a lot of times it's all here, it's next, it's trapped, they're just like, and then they aren't getting any of that good. And so sometimes we just have to like back up. Let's start with breathing first. Yeah. So I like to have people, I'll have people kind of give a little compression here, just in a little bit. And then as they try to inhale, they should be getting bucket handle action here instead of all this. So I'll tell them, try to keep your upper chest still. Kind of give them that little cue to press in a little bit so that when they inhale, they fill out hands laterally, because really it's like a 3D parachute. We should be expanding this way. We should be expanding laterally and not all belly, but we need that bucket handle motion of those lower ribs. And so if I can put their hands there and have them give a little pressure in, when they inhale, they should feel their lungs kind of filling out that way. And sometimes like we can't even work on other things till they breathe, and people have such a hard time with that. And I feel like for transverse abdominis, which is the deepest layer of the abs, and it has like a horizontal fiber direction, and that's what kind of comes in and closes the floor of that gap that we were talking about with the diastasis. But even if they don't have a diastasis, it still sits on the floor of where the six-pack is with a nice kind of horizontal fiber direction. And so if you don't have good activation of that, it's going to be really hard to strengthen your core. So I like to for people to kind of pair this with breathing so that they learn to not hold their breath when they're at the hardest part of their rep, or when they're exerting themselves or lifting their children or whatever. And so I like to pair that contraction with an exhale. So then a lot of people, when they think that they're tightening their core, they're just tightening and doing a Valsalva or just creating pressure. And so if they have a diastasis, then I see like the dome and the cone when they're trying to do that. And I'm like, stop. Right. So I have them inhale, fill the belly up all the way. Exhale, pull down and in towards their back. Right. And so usually I go diaphragm, abs, and then pelvic floor. Because like once I get those two pieces of that, I can get them breathing and contracting that deep layer of their abdomen with their breath. Then I go to the pelvic floor. And once we kind of, do any releasing that we need to, I usually I'm giving them some kind of manual cues, and I'll tell them inhale, fill the belly up, exhale, pull all the way down. Now pull up your pelvic floor and get them. Now, when you start to exhale, contract your pelvic floor up, inhale, relax all the way down.
Yes. And for those that don't know, a lot of times if you give yourself a manual cue, when she was talking about putting, hands on your ribs, a lot of times when you give your body that cue, whether it's yourself or someone else doing it, it's almost like a prompt. Like it's just a reminder of like, hey, you're supposed to move this way. And the physical touch a lot of times kind of helps that part of your body come along and play better. That's what I say, is that we want it to come along and play. And so that cue is more important than what you realize. Like you just think, okay, I need to feel myself breathe, but the touch back to your body is huge in sort of helping your body remember that it's supposed to move in that path. And so that's actually a really good tool that you'll miss because you think it's not important, but feeling yourself move is really, really important. And so that'll help you learn to expand your lungs wide, and like a lot of people, they breathe and they don't think that they should be wide whenever they inhale, but they should. And so use that. If you breathe, watch yourself breathe in the mirror. And if you are breathing up this way and your breath is inhale, exhale, and your shoulders are just up and down, then practice that and put your hands down there and really try to sort of push out, breathe in a manner that it would push out on your hands. And that's what's going to get you that width.
There's a great app that's like a breathing app that kind of takes you through like inhale, exhale over a period of seconds. And like, I mean, if we're being honest, good deep diaphragmatic breathing is more important now than ever, because I guarantee you a lot of the people that are being affected with COVID-19 can't get good diaphragmatic breaths, and all this sediment is getting stagnated at the bottom parts of their lung. Yes. So in order to kind of clear those secretions and keep our lungs healthy, we've got to be able to kind of move that diaphragm again through the full excursion. So full excursion is important with any muscle. And if it's not, a lot of times I'll have patients kind of reach under there, kind of in a little hook grab, as they just try to breathe a little bit and try to, give it a little sustained pressure, and then try some breathing. Just like if you were to hold some pressure on that knot on your neck, kind of curl under those ribs. Yeah. And give a little sustained pressure as they breathe to try to get a little release.
And people get junky under there. That's what I call it. Like you should be able to put your fingers under your ribs right there. And a lot of people can't. It's just junky and tight, and it's really, really hard. And it's like, it doesn't matter how hard you push, like you can't get any room up under there. And so even just trying to work your fingers in up under your ribs from that middle point where they kind of start to separate from right here at the bottom of your sternum, just working yourself down up under that rib actually helps breathing too. And a lot of people don't know that.
Well, and a lot of times that goes right along with the just restrictions along the entire abdominal wall. and anterior hip and the front of the hip, right? So, for like my first, year of practicing, I never thought about the abs being tight. I only thought about them being weak, right? So I was just like, it's just weak abs, you got a weak core.
Yeah, that's what everyone thinks.
But the abs are the same as, the pelvic floor, the neck, the back, anything else. Like, they can't be strong. They can't contract well or move through the full range if they're tight. And it's these people with these quad dominant, hip flexor dominant, their pelvis is tilted like this with that arched low back as that pelvis tips forward. Their abdominal wall is usually a hot mess and full of trigger points and junk, and they don't have any good fascial mobility, which is going to make that, diaphragmatic breathing that much harder. So yeah, I mean, that is like a huge area that I think is like overlooked as far as that it doesn't have mobility, much less strength,
And that pressure system that we're talking about with the breathing and stuff, like it's a dynamic system. Even like your pelvic floor, it should be dynamic. And there's things that should happen within it before you move, and it should be natural, and you shouldn't have to think about it, and it should be automatic. And so when we have dysfunction of how that system is working, when your body forgets or you've been through some kind of trauma or whatever the reason, then it doesn't work as it should, and that's when we have problems. So it's not a static system. Static means it sits in one place and doesn't move. Dynamic means that it's moving constantly, really. And so in this pressure system that we're talking about with your breathing and being able to move without pain and stuff like that, that system is dynamic, and all of the parts, all four of those top, bottom, and front and back parts are moving and working while your body moves. And when that gets disrupted, that's when we really have problems like pain and discomfort and incontinence and all that kind of stuff, because we're just kind of missing a piece of the puzzle. Okay, so let me show you how I do diaphragmatic activation. And so we have up here, it's your collarbone, and there's like a little U right here. And so from here to right where your ribs start to split down here, that's your sternum, okay, or your breastbone. And actually, if you will just rub it, and you can try this, just start from the top right here and rub it and press pretty hard. And that actually activates your diaphragm. It just turns it on. It's kind of like a pressure point, and it just, if your diaphragm is really off, then it's going to be sore to touch. And so sometimes I do fingertips like this. If I'm doing it on someone else, I'll make like a knuckle and reinforce it with my thumb. And then I do this to myself sometimes too. And then you just do it all the way down. If you're a woman, you got to go in between your boobs all the way down, right? And then that will actually activate your diaphragm. And so if you inhale and then do that activation and then inhale again, you should be able to breathe deeper. And what I find is that helps people with their pelvic floor, because it automatically helps change the way that you're breathing, because that one muscle is working. And then we can get you breathing wide and then get the pelvic floor going. And it's the same system that you use, Emily. I'm just kind of cheating to get that diaphragm to be active.
Perfect.
And yeah, but it's the same system, a little bit of a different technique, but that's something that you can do with yourself always. And it's literally, I don't want to say a life changer, but it's a huge piece of the puzzle in a lot of the people that I work with. And so same thing, breathing is so important, even for like, I mean, just like in daily life, if you're not even like an active person, it's important, because, oxygen is one of our main fuel sources. And if you don't get it, like your body can't function and you have problems. And so breathing is so important. It's as important as food, because it's, like our second food, like two things your body needs to survive. And one is oxygen and one is glucose. So super, super important. Hey, Emily, I had somebody post a question about what about a C-section? So let's maybe go in, it's not real specific. Cheryl, if you have a more specific thing that you want to know, post that in the chat. But let's talk about how a C-section sort of disrupts the system, and how to like help recover from that, and how it all pertains to the pelvic floor too.
Yeah, again, kind of like cesarean birth recovery is kind of like its own animal as far as like the the issues that kind of occur with that. The biggest thing that a biggest piece of advice that I can give people that have had a cesarean birth is that they need to move their scar, right? Because like we're never told to move scars. But if that was occurring in any other orthopedic population, so if I had a patient with a total knee or any kind of a, total shoulder that had a large incision, it would be absolutely expected that we mobilize that scar. And a lot of times but we are not told that about cesarean scars or any kind of other abdominal scars. And so you said I have an overhang in my belly, and a lot of times that's because like that scar has kind of dove in, right, and kind of gotten adhered. So there's layer upon layer upon layer upon layer upon layer that they have to kind of cut through to get a baby out, and they don't necessarily sew all those layers up. And so if this is all kind of drawn in like that, we'll kind of see this, I don't know if this is a word, but I call it caverning, right? Where it like draws in and then the belly kind of hangs over it. And to me, like that is an adhered scar. And so usually cesarean scars are like right here. And so usually that area from the pubis to the scar and this anterior hip is so tight. And then those kind of obliques leading up from that. And so some people are like, I don't want to touch it. I'm scared. It feels weird. And I'm like, start petting it with the cotton ball if we have to start there. Because sometimes you just have to teach your brain, like, this is not painful sensation. This is a cotton ball. We have to desensitize the brain. So like start with whatever kind of stimuli you can tolerate, a cotton ball, a rag, whatever. Start lightly petting it and then like work those tissues around it. So I usually have people, I'm going to show you on my belly. I'm not proud of it.
That's fine.
Okay. So like if somebody has like a tight cesarean scar, so they would be like right here. I have them kind of drop back into a lunge in the shower if they can tolerate it. And then they just kind of start scooping like this, like as they're kind of washing their belly and stuff anyways. And a lot of times it feels burny, right? So I just have them kind of get in there and kind of start scooping that lower belly. And if they can't even get close to the incision, that's fine. Start over here on the side of the hip and then start parallel with your incision. So it can start just as light as a pet, and then it can kind of work into parallel and then circles. And then you can do some kind of bending. And then if you can pick it up and roll it, that's ideal. Okay. But like cesarean scars, when they get adhered, talking about like that whole abdominal wall getting really tight, that affects breathing. They can also, like if that scar gets really bound down, contribute to urgency. So that is like, you're like, oh my gosh, I have to pee so bad. And then you get to the toilet and there's not a lot of output. And you're like, dang, I thought this was going to be a big one. So like the urge doesn't match the output.
Yes.
Or sometimes like you can't hold it. Right. And it's like the urge becomes so strong, it just starts coming out. And a lot of times that doesn't occur with coughing or sneezing. Those are the people, they're pulling into their driveway or they're walking into the door of the bathroom and it's like coming out, Yeah. And so a lot of times the urgency goes along with more of a tight pelvic floor, but this, and those lower abdominal restrictions that go along with either a cesarean scar or that posture where the whole pelvis is kind of tilted forward. So Cheryl, I mean, my first suggestion would be like start kind of working on your scar a little bit. I mean, of course, we don't ever want an incision to open and things. Yeah, girl, man, you need some help. But a lot of times when the scars get adhered, and those scars that do not sit flush with the skin but are diving in, and all that tightness that sits right here across the front of the pelvis, the bladder is right there. So if that scar is diving in, and then you have psoas and lower abdominals and pelvic floors that are so tight, then like our bladder can't expand far before it gets the cue of like, I have to go, right? And then this starts a whole nother topic, but like bad bladder health, right? So then, especially if you've ever had, an accident or anything like that, you get that cue to go and you just go. And then that teaches your brain that less and less urine needs to get into the bladder before you get the cue to go. Yeah. So like usually when we get our first cue to pee, it's only like 30% full. But if every time we're going when it's only 30%, then it'll be 20, and then it'll be 10. And then we have this teeny baby bladder that can barely hold anything before we're getting these like extreme strong urges to go pee. So, and a lot of that is like bladder health, bladder education, like reducing irritants until we can get the bladder to kind of hold a larger capacity, giving it as much space as possible as far as kind of freeing up all the soft tissues, you know, around there. So.
Well, and just so people know that, like, anytime you have any kind of surgery, it is trauma to your body.
Right.
And having a baby in itself is traumatic to the body because you carry for 9 months, and then you either go through a natural vaginal delivery or you get cut. And so
and honestly, there's no good way out.
Really?
Like both strategies, like you're not getting out better either way.
No.
Like, because, you know, like the cesarean births too, like after those abdominals are cut, like they're like, see ya, they just shut off.
Yeah.
You know, it's hard to get them to activate back on because the brain is like, no, that was a trauma, shut it down.
Yes, that's exactly my point. And so it's really important that you spend the time to recover yourself from that. And it's something that we miss in America because there is not good postpartum care for mothers. It's like, go home, chill out with your baby for 6 weeks. You go back to the doctor for a checkup and they're like, okay, you're good, get back to life. But there's no transitional healing is what I'll call it, where you're actually able to get medical intervention, and not in a way that like a doctor's going to give you a prescription, but like going to a therapist or, you know, seeing somebody that knows what's going on that can help you learn to breathe. Because after I had my child, like my breathing, like the whole system was just like, I mean, it was jacked. Yes. And, you know, I was really actually surprised when I started trying to sync my breathing, how off that it was. And, you know, you have things like I ended up with a herniated disc in my back, and, you know, like you get a side joint discomfort and pain, and you get low back pain, and you have all these different issues, and you're still trying to care for an infant at the same time and make sure you get enough sleep. And it's a lot of emotional stress. And so those traumas are very important for you to recover. Your body remembers a trauma. I don't care when it happened. So if you had a trauma that happened when you were like 6 and you were in a car accident and it threw you in the back seat, your body's going to remember that. And if you had a trauma when you were 12 that was some kind of huge emotional distress or emotional trauma that you went through, your body's going to remember that, and it reacts accordingly, and it's to protect you. And so it perceives that as threat, and it locks down and shuts things off. And so it's super, super important that whatever has happened in your history, that you spend time to recover that. And so Cheryl, I know it's been some years since you've had your children, but it still is relevant today because you haven't really taken the time to recover that. And so,
and it's never too late, Cheryl. Even people that are 20, 30, 40 years out from a C-section can still get improved excursion in their pelvic floor, improved mobility in their abdominal wall, and those urgency symptoms can be significantly improved, you know. And just another kind of state to that, to the trauma, you know, the same thing, you know, people that have had sexual trauma in the past, it's not unusual for them to have hypertonic issues of the pelvic floor as well, like of that pelvic floor to just be extremely guarded and tight, you know. And like we can do kind of all the pelvic health physical therapy in the world, but a lot of that is your body kind of trying to guard, you know, from previous traumas. So of course, like addressing that trauma with, you know, appropriate mental health professionals is sometimes the key that people need to kind of unlock that as well. Because if the brain is guarding that because of a history of trauma, you almost always have to have a mental health component kind of going along with the physical component.
And emotional health, just since you're going that direction, just to touch on it, it plays a huge piece in pain in your body. Like your body remembers what it's gone through. And so if you have an issue that you've never dealt with, whether it's, you know, sexual trauma or the loss of a close family member or friend, or you know, it doesn't really matter whatever emotional trauma that you've been through, like your body hangs on to that if you've never dealt with it. And so it's super important to deal with those kinds of things and figure out how to release those emotions, whether it's talking about it or journaling or, you know, doing other kind of emotional release techniques to get that out of your body, because your body will harbor it and it will present as pain in your body. And that includes, you know, hip and pelvic pain. And so if you've had like an emotionally stressful pregnancy and then had your child, and then you end up in like postpartum depression, and then you have all this other emotional stress, like that can be a huge component to what's going on in your pelvic issues if you're having pain. And so don't disregard that. You know, it's super important. The body works together, and that includes your mental health, your physical health, things that are working or not working inside your body, and a plethora of other things, environment, how you're feeding yourself, do you have inflammation or not. And so it really is a masterpiece, and things work together just like, you know, that piston breathing system in your body works. Your whole entire body works that way. Like it's just one piece that needs to sync together for you to be optimal.
Yeah. That was an awesome monologue.
Hey, sorry. Well, the pain thing is my thing, you know? And so even though like I work in like personal, like health and fitness coaching, pain is like, because I've been through it. And so it sucks to be in chronic pain. And like, that's just kind of my thing. But okay. So did you have anything else? We've been on for about an hour. I feel like that's enough time. If you have questions, I want you to drop them in the chat real quick, because we're going to stay on maybe another 5 minutes. I just want to make sure that, Emily, you don't have anything else to add or tips or anything like that. I feel like we've covered just about everything that was on my list. And I'm going to send out the PDF that Emily sent of the stretches. And then I'm also going to send you some information from me that's going to be about feeling your pelvic floor work. And then I'll include that, how to activate your diaphragm, and then a couple of other exercises that are really useful for kind of getting those parts to work together. So Emily, did you have anything else?
Yeah, so on that exercise sheet, you know, one of my favorite kind of go-tos is like a hip opener, right? So I love like a hip flexor stretch with an arm oblique trunk stretching component, because a lot of times, again, like we talked about, that abdominal wall getting really restricted. And so stretching that hip flexor really well while we're getting that side bending and opening up that oblique just creates more space for those abdominals to kind of move through the full range. I also put like a happy baby supine pelvic floor stretch, which again, if you're working on like deep squatting or anything like that, and you're having trouble getting down there without like butt winking too early, a lot of times that is these kind of pulling that pelvis down at the end of our squat, which can kind of so that first one is that hip flexor with the side bending. So I like a good triplanar stretch because that's how we move. It's really important to remember that when you're doing that, you've got to tuck the tailbone under. So if you just feel like you're lunging infinitely, there's like 100% chance you're doing it wrong. But if you like tuck that tailbone on that knee down, you should immediately feel that stretch across the front of the thigh. And so then if we add that good arm in there, then we can kind of start to open up that whole trunk. Mm-hmm. The pelvic floor stretch, I mean, I have men and women do this. That's important for like a full range squat. If you're working on kind of increasing your load, or you just want to get down on the floor easier. Again, pelvic floor attaches to the tailbone and kind of all those things. And so if we can stretch it out, that will help with improved kind of mobility through the full range as well. So I put a good stretch there. And then I love this way of learning to activate deep abdominals on all fours, because you can essentially let your belly dangle, and then as you exhale, pull your belly up without moving your back. And I think this is the easiest way for people to do it at home without cheating.
Yeah.
Because they can work on like, all right, I'm gonna keep my back still, I'm gonna let my belly dangle, I'm gonna exhale, pull it up, and they get to feel pulling their belly up. Okay. And it's harder to just like come into a full pelvic tilt or just get rectus abdominis like they will do on their back. So I put that one on there. I like that one a lot. So usually if I can't get them to activate deep abdominals on their back, I'm just like roll over. And then, was there one more on there?
Yeah, the piriformis.
Oh yeah, and I put some a piriformis stretch on there as well, just because like, again, if we don't have good hip mobility, then everything else in the system, our back, our abdominals, our pelvic floor, are kind of all going to come into play. So hip mobility is a big thing for me. So lots of hip openers and some deep abs.
Yeah, that's good. I find a lot of people that are quad dominant and tighten their hip flexors too. And for those of you that don't understand quads and hip flexors, it's the front of your thigh and then that open-ended front part of your hip is what we're talking about. Yeah. And so it's just right there. Yep, that's it. And so you can actually tell that people are tight that way because they'll stand and they'll be kind of like in this position. So any bend of the hip, they'll be kind of like, sometimes I can't do it to like explain it.
They're like this. They're like
this. I can't do that. It's my SI joint.
It's like tipped and so they're like, their whole pelvis is like tipped and like their body is like a degree or two forward flexed.
Yep.
And so then their back is trying to pull their body back over the base to support. They have these just tight backs, limited hips, and no glute function.
And if you've had a baby in the very early stages of pregnancy, your glutes just shut off and they stay off for the rest of your pregnancy. I actually felt that happen. And so
that's why you get mom butt.
It's part of the problem.
Yeah. Yeah, and like the pelvis has to do that to accommodate a growing baby, right? And so like it has to tip to create more space, but then we just end up with these really tight quads, tight hip flexors,
non-bod,
inhibited glutes, and then we're just like, go back to what you're doing, it's fine.
Yes.
That and like when you talked about postpartum recovery, that is like my biggest soapbox because I'm like, if every woman got the rehab that they needed after a baby and they had their whole musculoskeletal system checked from their neck to their foot, because all that's impacted with postural changes associated with pregnancy and laxity, then people would have a much more successful return to fitness and be able to carry their babies and lift them without pain.
Yes, or peeing on themselves.
Yeah. And so like, I guess my like final point is I want to just drive home what is common is not normal.
Yes.
Right? So people are like, but I just pee when I jump on the trampoline, but all my friends do that. And I'm like, not normal. Like that's pelvic floor dysfunction. And just because it's common and lots of people deal with it doesn't mean that you're not having issues. You know, constant aching in the pelvis, not normal. Maybe like common, but not normal. Pain with intercourse, not normal. Any position, any way should be fine at any point. And if it's not, like we might have dysfunction. I mean, it's normal to go pee like once every 2 to 4 hours if you're non-menopausal. Really no times at night. If you are menopausal, we give you one. Yeah. But like anything more than that, you know, we're kind of getting outside of the realm of what is normal. And so just kind of, you know, educating people on the fact of like what may be common is not necessarily normal, and that these muscles kind of play a big problem, and we want to think that this is a bladder problem or this is a rectum problem or this is a constipation problem, but a lot of this is just a muscle problem.
Yes.
And they have the same issues anywhere else in the body would have. They get tight, they get weak, they get trigger points.
Yes. And
sometimes they tear during childbirth and stuff. You know, but they have the same issues that anywhere else can have. And a lot of times if you improve their mobility, can improve their strength and their ability to have excursion through the full range, their function, which is a lot of times continence and things like that, improve. So
don't forget about your pelvic floor. That's what you're saying.
Don't forget about your pelvic floor ever.
Okay, so a little bit, I should have done this in the beginning, but I didn't give you information on Emily that she actually specializes in pelvic floor. And so she is a physical therapist, but do you do other kinds of therapy too, or are you just 100% pelvic floor?
No, I do everything. Like I've been an outpatient orthotherapist for my whole career. It's so like used to kind of treating everything kind of head to toe. Just kind of started moving into pelvic health probably 2 to 2.5 years ago. I specialized.
Is that what you're most passionate about, is the pelvic floor health?
Well, I really like pregnant and postpartum women, right? Because I feel like if I can get them right after they have a baby,
Yes.
like that's but I don't treat men internally, but I have colleagues that do.
Okay.
I still talk about it with them.
Yeah.
I, so like one of my colleagues, Nikki Woods at our Homewood office, she does vaginal and rectal work, which sometimes rectal work is more appropriate for those significant kind of coccyx pain issues or fecal incontinence and things like that. So I like to think of myself as like ortho with a splash of pelvic health, because I like to treat the pelvic floor as it relates to the hip, the back, the SI joint, kind of making the whole system, the kind of whole picture work together. Because same thing, if you just treat the pelvic floor, but you aren't working on their hip and their back and their abdominal wall, you're going to start spinning your wheels as well. So I do, I like working with that. And I have an Instagram account on like postpartum recovery and pregnancy and different kind of pelvic floor things called Mothers on the Mend, that I post some different videos of some of these exercises and stuff that, whatever.
I'll include that in the email too, so people can connect with you there. I think I'm connected with everybody through Facebook, and so I'll include that in the email, just so if people need to reach you, they can message you there.
And like feel free to put my email on there, or like whatever, if people want to like reach out and consult about what they're dealing with, or if they felt like they would benefit from physical therapy. I'll be happy to consult with anybody.
Awesome. Okay. And then whenever the coronavirus situation settles, we are going to do an in-person get together. And I'm looking to bring in like a couple of other people. Like I would like to get a yoga person that specializes just in, some of the pelvic floor work and stuff like that. And so we do want to do an in-person workshop. I think the virtual thing was great, but there's something about physically going and being able to walk people through exercises and helping them feel what's going on with their body that's really important. And so I'm kinesthetic, so I learn best by doing. And so I think that's why I like that way best. But I do appreciate you taking the time to chat with me about it and to let everybody come on and get some more information and stuff. And I will include your, I was going to say connection information and the email that I'll send out tomorrow with the replay. So if nobody has any other questions, that's all. And I'll let everyone know about whenever we decide to do an in-person thing. Who knows how long that's going to be.
Perfect.
So all right, Emily, thank you. Have a good day.
Thank you. Bye-bye.